going to be useful. It's a topic that I don't hear too many people addressing.
Okay.
And we thought this time of day was a good time.
Yeah. It's like,
Friday afternoon.
we'll see if we can spark you up a little bit here. Okay. Can I get a show of hands for who I'm dealing with here in terms of, let's go, I know there's social workers? No? OTs? PTs? Nurse? Physicians?
We have physicians who are alcohol.
Okay. So pretty wide group. And basically, psychology? Okay. Basically, what I've been asked to talk about is sexuality and geriatrics and how this affects rehab. And so we're going to go, it's a pretty wide topic. People can spend their lives studying these sexuality. And so we're just going to do an overview. And basically, what I want to do is define sexuality, talk about getting the history, factors affecting sexuality, and then a model that you can all use, the implicit model. And then we'll look at some myths and taboos and then talk about sexual function. And I know that we're scheduled to stop at 3:30, so we may have to cut some of this short because I'm sure you guys are all heading out to Fiesta de Tejas, right? The reason you don't have any parking out there. All right, let's talk about the definition. Let's see. Francis, when you saw that sexuality topic on that handout, when you were coming here, what did you think of? What did you think I was going to address?
I guess I was encouraged because I thought, oh great, when I'm 90 I can still be sexually active. Not necessarily maybe having intercourse, but I can still express myself.
Okay, so you've hit on a good point. I mean, what is sexuality? And one of the things that we have to remember is that a lot of people, when they define sexuality, are talking about sexual genital intercourse. And I'd like for you to think about it as more of a communication intercourse, all right? That anybody is entitled to sexuality. And I think the slides are going to have to be turned a little bit here. That sexuality is rooted in the human need to relate to others, to receive and share pleasure, to love and be loved. And it's a form of communication. So you can see that in my specialty, rehabilitation, we deal a lot with people who have amputations or people who are paralyzed, either on one side or from the waist down or the neck down. And there are people in the population who look at them and say, well, they can't have genital intercourse, therefore they can't be sexual. And the whole thing is that if you widen your definition to include communication in any form, whether it be between two people who are of the same sex or different sex, it doesn't matter. This is a form of sexuality and communication. So Francis was absolutely right. When you're 90, you're still going to have the means of having some form of sexuality. You don't want to be thinking of only genital intercourse. The lights are a little bright. I mean, can we light? Yeah, okay. And I think that this is a really big problem with the residents. Whoa. I don't think it changed anything. I'm sorry. When I deal with the residents, when I ask them, have you gone in to talk about sexuality, they personally say, well, they can't do intercourse, and so we haven't talked about it. And so it's a big issue to expand the minds of the people who are dealing with the clients that this is not the only thing that we're talking about when we deal with sexuality. All right, this is just so that you will be coming from the same basis that I am. When Masters and Johnsons did their typical male and sexual response, they identified the male response as having excitement, plateauing quickly, and then having an orgasm with resolution. All right? New research has shown that the male is not limited to that kind of response as had previously been reported. The female has very many options. They're going to have excitement and stay for a long time in the plateau before they have the orgasm. They may never have the orgasm. They may stay in that plateau and have very small orgasms, or they can have multiple orgasms. All right? That's what you typically read in the magazines when they're talking about sexual response. The key to this is that you understand that anybody can have any of these responses. Just because you have one response one night, it doesn't mean you have the same response the next morning. All right? So when we talk about the elderly, one of the things you should be thinking about is what happens to them in physiologic changes. And the biggest thing is that in the males, the excitement phase is that it takes longer to get an erection. All right? So where maybe it took 5 minutes to get an erection, now it might take 10. And the plateau phase lengthens. So they become more like the female, and then they have a longer plateau before they have the orgasm. Now, the sensation of orgasm changes a little bit because they may not feel, this is often referred to as, by males as the sense of inevitability, the point of no return, where they cannot control whether they're going to have an orgasm or not. And often as men get older, that point, it's kind of like one man described it as, by the time I think I'm going to have an orgasm, I've had it. All right? But they still have it. Now, a lot of men will come into the physician's office and say, I'm having premature ejaculation for the first time. Never had a problem with it. And that's what they're talking about, all right? Because they don't feel the same. It's not quite the same as it used to be. With the other thing that happens with the males is that after the resolution, the refractory period becomes longer. So in a teenager, they may be ready to have sex again in 5 minutes. You know, they had one orgasm, they're ready to go again. And as the clients get older, that time period becomes longer, and it may take a whole 12 hours before they're ready to have an erection again. And that has to be explained to people as being normal physiologic. Because what happens is that if they don't know that that's normal, they become involved in the having to perform. Okay, so they get a performance anxiety. They have an orgasm, and then let's say their wife wants to have intercourse again the next morning, and they're not able to get an erection. So all of a sudden in their head it's like, my penis isn't working, and then that becomes more and more anxiety. Okay, so if they're taught the normal physiology, they won't be worried about that. When we look at females, what we're looking at, vaginal lubrication is equivalent to the penile erection. So in females, they have a very significant change at menopause, a very significant hormonal change. And because of that, they will have vaginal lubrication that will decrease, and the walls of the vagina will get thinner. Now, the ways to prevent that are to have estrogen therapy, whether it be orally or transdermally, actually putting it on the outer genitalia and in the vagina. What often happens is women go through menopause and are reluctant to take the hormones, go through some of these changes, then start having painful intercourse. Once they have painful intercourse, of course, they're not as interested, and so then the decline in interest becomes. So again, if they're having good responses with their OB-GYN, their gynecologist, their family practice physician, this kind of problem can be avoided by education. It seems that in both females and males, the old adage of use it or lose it is very appropriate. The more active people are as they're younger and maturing, the more active they will remain. They did studies where they looked at master's level swimmers, and they compared people who were 40-year-olds to 60-year-olds. And the 40-year-old masters competitive swimmers had a sex life that was as active as normal 20 to 30-year-olds, and the 60-year-olds were the same as the 40-year-olds. And so it goes to show you that the healthier, more active people who have active lifestyles are more likely to be active in their sexual life as well. And I think that is common sense, but it's a good reason to think of yourselves that, you know, if you're looking at growing older and saying, oh my God, I'm going to look like my grandmother, and you know, she hasn't been in bed with her husband for 20 years, you have to understand that there are many issues, and that doesn't necessarily mean what's going to happen to you, okay? All right. That's a general overview. We did a study in 1983 where they looked at patients coming into general family practice office. And they found that 53% of those patients who walked in for any other problem had problems with sexuality. Okay? And what they discovered is that physicians don't ask these questions. And that's why they didn't know that it was so high. And when they asked the physicians, why don't you ask sexual questions, they said, A, we don't think it's important to the patient, which of course it's not my decision to decide whether sexuality is important to you. Okay? So they were making an assumption. B, that they weren't trained to ask those questions. And I can tell you that in the 4 years of medical school, I had a total of 2 hours in psychiatry on sexuality, and one of those hours was on sexual deviant behavior. All right? So we are not trained, and that's a fact. And the reason that I'm standing here talking to you is it just so happens that I was comfortable with the topic, and I was dealing with it in rehab in spinal cord patients, and became able to, I was comfortable talking about it. It became obvious that it was an important issue, and so I have pursued and am discussing it with you guys today on geriatrics. The third thing is the physicians are uncomfortable. Okay? I mean, they're not comfortable with their own sexuality, so let alone asking somebody else. When they tried to convince the physicians that there was a good reason for asking asking sexual histories, they came up with these 4 reasons. That it enabled the physician to find out whether it's important to you. So if I ask, I'll find out. The other thing is, if I find out and I said, okay, are you having any sexual problems? And you say, well, as a matter of fact, it kind of hurts, and so we've stopped having it. We may do a pelvic exam and find out a reason for you to go to the OB-GYN. We may find out you need hormone treatments. For males who are having erectile problems, we may discover that it's a normal side effect of one of the medications and may be able to change the medication. But if you don't ask, they're certainly not going to volunteer it. Okay? The other thing is, this may be one of the first signs of atherosclerotic disease or diabetes, and that may be the first thing that's happening is either a loss of erection or it's slowing down. So if you ask these questions, you actually are going to get some information that is medically important. The other thing is that it affects the psychosocial environment, because if your patient is standing in front of you saying, I need a prosthesis in my penis because I need an erection, and then you start asking questions and you find out that the real problem is that his wife doesn't want to touch him, then you've established that there is a bigger problem here, that it's not that he's not getting an erection, it's that he and his wife are having problems. Okay? So you're addressing psychosocial issues. We have a lot of patients who are 18, 19 years old who are paralyzed, and they absolutely want to be able to get an erection. And you say, do you have a girlfriend? Do you have a partner? No, but I will get one if I get an erection. It's like, no. Let's go back to step 1, communication. All right? And so that's part of education. The 4th thing affecting the overall treatment and follow-up plans is the idea that if you have a patient who has high blood pressure and you know that their sexual intercourse is absolutely important to them, and you know that ahead of time, and you warn them that the medication that you start them on may cause impotence, and then you're telling them, come see me and we'll deal with that issue. We have had so many cases in the hospital of young 40-year-old males, and it's often black males because they're the people who have the trouble with hypertension, who aren't, this issue is not discussed with them. They stop taking the medications because they've made the connection, and then they have a major stroke. And then what are you supposed to do? All right? So again, it's communication not only between patients and their significant others, but between between us and the patient. This brings up the issue of you can't decide when you look at the patient what kind of sexuality is important to them. All right? And there's so many perceptions in our world that people who have had strokes, people who walk with a walker, people who are in a wheelchair don't have sex. All right? And you're shaking your head. You have had that experience?
Oh, I've seen people who say that. I was in a wheelchair for 8 years.
Ah, okay. So you speak from experience. Okay. And so this picture is to remind you that when the OTs and PTs are dealing with her in her wheelchair and they're training her, they also have to realize that she's going home to a partner. Okay? And so some of these things, we'll talk about it a little bit more. The reason that I bring up spinal cord so much is that 50% of them are between 15 to 25 years of age. And that's a really important time for sexual development and interest, right? So, and the other point is that 15% of them are females. And so the literature is really poor when it comes to females and sexuality. And most of you are females in here. And you should know that that's still true even in the able-bodied population. Okay? There's all sorts of literature out there on why men don't have erections and what kind of angles their erections are. But nobody talks about the females. All right? And then when you put on top of that ageism and you deal with the idea that older people don't have sex, then why do literature on it? You know? So there is a real lack of information out there on what's normal. When this is going to put it in perspective, when you hear that people become paralyzed, this is a spinal cord unit in Vancouver, and they have a full-time clinician who is a non-physician, non-psychologist, and all he deals with is the sexual issues. And they found in their study that if the clinician did not inquire about sex, basically the patient felt that their sex life was over. Okay? So you may not say anything about their sex life, but if you're not even comfortable asking about it, they're going to perceive that to mean that it's over. And that their concerns were often present soon after injury. As a matter of fact, it was often the question that was asked before they asked could they walk. That was a very important question. And I had a very telling experience in our hospital where a young man was he was 45 years old, and he was wondering about his walking, but the sexual issue was one of his major concerns. And I got called in at 7 in the morning by the neurosurgeons because this man wanted to talk about sex. And it brings up a real important issue that I'm going to talk about is that if you personally don't feel comfortable, make sure that you don't turn that patient off and that you allow him or her to talk to somebody else who is comfortable. And so I've developed this relationship with the neurosurgeons, who are mostly males, that when this comes up, they call me, okay? Because, and at least they call me now, all right? And, but it was funny because this gentleman had been hurt like at 3 in the morning on Saturday morning, and they were calling me at 7 on Sunday to talk about this. And I was like, I can come in on Monday and talk about this. Remember that disabilities, sexual disabilities can be psychological, social, or physiologic. Okay? So there's all different types. And this will be very important in the elderly because if you read some literatures, they'll say that 90% of impotence in males is due to psychological issues, and then the next paper will come out and say 75% of it is due to physical features. So I think both of them are very gross exaggerations, and that the real answer is that it's a combination of both. Okay? Can you come up with some factors that affect sexuality? Think about it yourself. While you were in the wheelchair, what kind of things affected your sexuality that you were aware of?
Attitudes.
Attitudes of other people?
People treating you like you were an object.
Okay. All right. And that affects everybody. If I walk down the street and a construction worker says something to me, then I feel like an object, right? So attitudes are very prevalent. What else affects them? I mean, why did you choose to wear so many bright colors today?
Because I'm not in the clinic working.
Okay, so you're projecting something, right? I mean, it's your body image, how you feel about yourself. And all of these things affect sexuality. So one of the first things is self-esteem, all right? As people get older, things happen. People may become incontinent and have to wear Depends. Now, how is that going to affect sexuality? Picture a woman who loses her husband and is incontinent. She was comfortable with it with her husband because they had dealt with that, but now she's going to go out there and meet somebody new and have to explain why she has a diaper on. All right? So those are issues of self-esteem, and unfortunately what happens if we don't intervene with that is that it becomes a roller coaster. They feel bad about themselves, therefore they hide. Okay? They hide themselves and therefore they don't meet anybody. And then they sit around saying, why don't I have any friends? And it becomes this roller coaster that we can hopefully intervene and break up. This is a big issue in our culture. The idea of perfection is always around us, okay? So the male has this portrait of what he's supposed to look like, and as they get older and may develop a paunch or, you know, not be quite as beautiful, it becomes an issue of self-esteem. Body image, all right? And that, I think, is a big important part of us. I mean, how many people feel uncomfortable when they put on 20 pounds? All right? How many people have one wardrobe for when they're on their high side and one wardrobe when you're like me and you've had Clostridium difficile for a month? I was really sick with this diarrhea for an entire month. And it's like, okay, I can't fit into any of those clothes, and now I'm in my thin clothes. And so body image is very important, all right? And when you're looking at this, you have to remember that everybody has their own body image. And most people will look at this and go, oh man, if I look like that, I wouldn't have sex. Well, what if you did look like that and wanted to have sex? You know, you have to be able to have your own self-esteem and sufficient body image to be comfortable with that. And that's part of what happens with clinicians, because if you're not comfortable with yourself, you're not going to be comfortable with your clients. This brings up the issue of adaptive equipment. This is a really old picture of it. It's a leg bag. And if your patient has something like a leg bag or a colostomy, you know, that has to be incorporated into their body image. And then they have to explain that to their partner. And it can affect how they feel sexually and whether they want to be intimate. Gender identity and role. As the elderly get older, let's just say a traditional couple where the male has been the person who has been bringing in the money, has been in the supportive provider role, has a stroke. And now the wife has to go find a job. This is going to affect the bedroom, all right? Where the male traditionally might have always been in the missionary position, and now he's paralyzed on one half of his body and he can't do it. Are they going to stop having sex? They will if they don't talk about it. They will if you guys don't talk to them about other positions. They will if you have no idea that they're having a problem. All right? Yes?
I've seen another factor that is important, especially in women, are a mastectomy. After the mastectomy, when they have been on chemotherapy that can cause ablation, total ablation of the ovary, no more estrogen production, then that is another factor that really...
That's absolutely right. And it goes...
Women will be maybe scared to be on estrogen because they know it's another risk factor for another type of cancer later on.
Right. And given what we're talking about, it can be both ways. The woman might feel damaged because of the mastectomy, and their body image and self-esteem is poor. On the other hand, the male, her partner, may feel that because she doesn't have breasts anymore, she might not be interested in sex. And so it requires education that the libido is in the head. Okay? And this brings up the idea that again, when you're focusing in therapy and in the office on specific tasks, remember that that patient is a whole patient. And I think that you've probably heard enough today that in rehab we look at the whole patient, okay? We don't focus in on one part. This is going to take some getting used to. It's a female in the missile with the bomber beefcake. And again, this is the idea that sexuality is an issue that is really dependent on where you were raised culturally and in the time, all right? A lot of the research that was done by Masters and Johnson was done on people who were raised in the 1880s, Victorian age. And these are the elderly that were being studied by Masters and Johnson. And so that's a whole different way of living than you guys have been raised in, okay? And so you have to take that into effect. I mean, something that may be comfortable for me may not be comfortable for my grandmother because of when she was raised and where she was raised. And you have to take that into account. So let's talk about the model that is very simplistic. It's an acronym. The P stands for permission, the LI for limited information, the SS for specific suggestion, and IT for intensive therapy. I would think that all of you in here who have one-on-one contact with patients should be comfortable up to the limited information. For some of you, those of you who are therapists, I would expect you to be up to the SS, the specific suggestions. Psychologists would be up to the specific suggestions, and RNs and LVNs ought to be up to the specific suggestions. All of you in this room, or anybody in healthcare, better not stop at the level that's not existent here. I mean, the P is what we talked about when we said Rusty makes his move. If you can't even allow patients the initial start of asking the question or offering that, hey, I'm not comfortable talking to you about this because of my religious beliefs, but I know somebody who can, all right? So that's the basic level of P. And it's very interesting that the patients, again, I deal with a special population. So if I'm dealing with the spinal cord patients, they're usually males. They're usually either Hispanic or black. They're often in gangs. And they're often in a non-wealthy environment. And they're coming to me, and I'm a white woman asking them whether they're getting erections. All right? They're not interested in telling me. But I start off by saying, when you come to clinic, I'm going to ask you about your skin, your bowel, your bladder, your sexual function, and your mobility in your wheelchair. And whether you have any problems with those, I will always ask you about those 5 things. So the first time I say something about sexuality, no, don't want to talk about that, it's not important. Fine. The next time they come in a month later, I say, okay, skin, bowel, bladder, sex, mobility. No, don't want to talk about it, don't have a girlfriend, don't worry about it. And the third time, they're like, when are you going to get to that sex question? Okay? And what I have done is I have created an atmosphere that lets them know that I'm going to talk about it, whether they're comfortable or not. And so I've given them permission. And when they realize that you're going to follow through with that, they will become more comfortable. All right? So again, I'm not saying that you have to plow this down their throats. You just let them know that you're there and that this is important and that you acknowledge it's important for them. The limited information are things that you have if you're interested in arthritis. You might have the little handout from the Arthritis Foundation that gives different sexual positions for people who have sore joints. All right? There are positions for people who have emphysema and COPD because they can't breathe in certain positions. There are pamphlets and books on spinal cord injury on if somebody is paralyzed, what kind of position. All right? And this is beyond the normal books like, you know, The Joy of Lovemaking or something like that. I mean, that's one book, but then there are very little specific handouts that can be unobtrusive to people, unoffensive to people. The specific suggestions would be more like, this is a case of this guy is paralyzed from the waist down and has very poor trunk control. So if he were to try to undress himself, again, that's part of maintaining body image and self-esteem is I'm going to undress myself instead of having somebody else do that. What the therapist came up with is using his partner as the backboard. So he's able to get into bed and take care of himself and maintain his independence, and at the same time she's not having to undress him. All right, so that's an example of specific suggestions. I certainly can't go through all of them. This is some practical guides for spinal cord patients, and I've mentioned some of the others. And then the IT, the intensive therapy, I would think that nobody in this room is ready for. I mean, these are people who usually are psychologists or social workers who have training in sexuality, okay? So if there's things like vaginismus, where the woman cannot relax enough to allow penetration, or there's impotence that people think are psychologic, or there is dyspareunia, which means painful intercourse but with no, there's no physical reason. Those are the kinds of things that need intensive therapy, okay? I'm not trained to do that kind of intensive therapy, except for maybe with spinal cord patients, okay? Because I know of specific things I can do there. But this would require a referral to somebody. But again, you have to ask the questions or you won't know whether they need it. Given the whole body, I can't read your name tag, so I'm afraid I can't ask any questions over here. I want to know, what is the most important sexual organ we possess? The brain, okay? And the second most important would be, this one says, we had to remove your brain for a couple of days, so try to relax. But the point was, he's not going to be having sex because he doesn't have the brain. And I think that you can realize that in most patients who are aging or in disability, the brain is still there. Okay, so that's what was one way to remind you that sexuality is a big issue. This is what a lot of young kids will answer, right? Young kids, teenagers will answer that the most important thing is the genitals. And this is a wooden float. It's actually a float that is pulled by horses in Japan. It's in a fertility festival. And the idea is that we have to get away from the impression that the genitals are so important. Okay? And we've already talked about that when we said that genital intercourse was not the main thing. And that just because that didn't work doesn't mean you can't be sexual. Skin, all of us have skin, and again, we need to learn how to use it. Okay? I mean, I need some help with that. We're in the myths and taboos section here. All right. The gentleman with the tan suit. What is this?
Like some kind of a torture device.
Torture device. All right. Anybody else? Well, it's actually, I think he would call it a torture device because it was meant to go over the penis. Only, as you can see, that as long as the penis remained limp, they were not in any trouble. But the moment they started getting an erection, they hit the spikes. Okay, so that was used on young boys to prevent masturbation. And this would be more of what you were thinking of in terms of the chastity belt. Now, the female chastity belt was basically a whole body shield because they couldn't keep us away with just this little thing. And they had to cover the nipples. And they found, I found very fascinating, the woman, Alice Walker, who wrote the book, The Color Purple, and some of the other books, her last book on the temple, something about the godmother's drums or something like that. I'm forgetting. And they talk about clitorectomies, and they focus on it in Africa, right? The idea that you've heard this on 60 Minutes, but what's really interesting is that this was done in the United States, and that when the slaves were brought over from Africa, doctors would stand, watching the slaves on the blocks and examine these women to see what had been done. And then they started using that surgery on people here in the United States to prevent masturbation. So if somebody brought in their young girl and said she's masturbating, the doctor would do this. And so don't think that it didn't happen in the United States, all right? And this is a big issue when it comes to masturbation, because in the United States, it wasn't until the 1959 textbook came out, Campbell's urology textbook, that they finally admitted that masturbation would be okay, and you wouldn't have, get epilepsy and be demented and end up in a psychiatric hospital and go blind and grow hair on your palms and whatever else these other myths were. Okay, so this is 1959, so think about, your parents or your grandparents growing up going to doctors who haven't read that textbook yet, all right? So there was a big issue, and a lot of people are still very uncomfortable with it. And when you look at the statistics of females to males as the population ages, masturbation becomes a real possibility for sexual release. And there's a lot of females who have been taught that this is not appropriate. In this day and age with AIDS, it is one of the only forms of safe sex, all right? And my chairman knows that I talk about this, so you can't get me fired. But it is something, for instance, we've just opened up a 27-bed rehab unit in the hospital. And we have a policy on conjugal visits, and we have a policy that allows patients to tell us that they need some privacy, and we allow them to do this, all right? And it becomes an issue of allowing patients to experiment. If, for example, the woman is having difficulty with lubrication, you need to teach them that there are things out there. There's a product called Replens. There's, all kinds of lubrication that can be used, and that they don't have to focus on intercourse, that there are other things that can be used, and they may not know that, all right? You may have to give them a book. You may have to talk to them. This is another taboo. It's anal intercourse, and it became a big issue with AIDS because the studies showed that in a population here in San Antonio, when an OB-GYN physician polled all of his patients coming in, and he looked at 900 patients, 25% of those women, mostly white, upper middle class, admitted to anal intercourse, at least trying it once, and that 8% used it as a regular form of sexual activity. And what happened with the AIDS epidemic is that all of a sudden everybody was saying that this was a gay disease and that it came from anal intercourse, and they were forgetting that that also is a heterosexual activity. And in Africa, when women have been mutilated with the clitorectomies and the vaginal suturing, often they engage in anal intercourse because that's the only thing that doesn't hurt, and they can have an orgasm through that, all right? So you have to make sure that something that you find totally gross and inappropriate, you don't let that, you don't force that on your patient, because your patient may think it's great. With patients who are paralyzed, often one of the only thing that is saved in terms of sensation is right around the genital area. And for a male, because of the different levels, the penis and testicles may be totally insensate. They cannot feel a thing, but they may be able to feel around the anus. And believe me, when they experiment and they find out that that feels good, they will start to do this. Doesn't mean they're homosexual, okay? So again, you have to broaden your horizon as to what happens. Do elderly people do this? If you're having dyspareunia because your vaginal walls hurt because they're not lubricated, you may indeed try this, all right? And so this is not a taboo. I mean, it may be to you, but it may not be to your patients. Obviously, sexuality does not have an age limit. That's why we're talking today, right? We're making sure that you guys don't have preformed ideas in your head as to when it does and doesn't happen. And this young girl who's paralyzed at the age of 14 months, her parents need to know that as she grows up, there's going to be different issues, all right? So that you have to realize that this happens from a very young age to the very elderly. And what often happens with children who are disabled is that the parents treat them as children all the time. And this young girl is going to grow up having people stick catheters in her urethra. And so she's going to be real used to opening her legs to anybody who has the catheter to stick in. And she's going to have to be taught the difference. And if nobody takes the time to teach her the difference, when she gets to school, there's going to be a problem. All right? There's also going to be a problem because she's in a wheelchair, and how's she going to go to the dances? And how's she going to experiment? Okay, so those kinds of issues have to be addressed with the family members. Slides just to remind you that it's communication that matters, right? And that undressing can be a sensual experience. And I think, I don't want to keep you guys later. I know what it's like to be kept later than you have to be. The next part, we were just going to talk a little bit about sexual function itself, and actually how to screw is that's the slide. I think this is the key. Remember that for erections and lubrications, you need three things. You need your sympathetic system, your parasympathetic system, and you need blood flow. So what happens as the elderly age is that blood flow goes down from things like diabetes. If they have heart disease, chances are there's something wrong with their blood flow through their genitals, all right? So peripheral vascular disease, people who smoke a lot, the blood flow will be affected. Then if they have problems with paralysis or strokes or peripheral neuropathy from diabetes, then the nervous system will be affected. Again, remember that the brain is the important thing, right? And so there are a couple ways of having erections. And one of them is called a reflex erection. And for those men who are in the room who have gotten erections from bumpy school bus rides, when they were kids, they know what we're talking about, all right? I mean, it's not like the school bus ride is exciting, it's just that it's a reflex, all right? And so as nurses, you guys have to understand that if you're dealing with some patients and as you're doing the INO catheter and you're manipulating the penis, it may not be because you smell great that day, it's just because you are causing a reflex, just like when you hit the knee and it kicks out, all right? So that's one way. This is kind of what slows down as men and women age because it takes more stimulation to get that reflex going, the lubrication going. So whereas I might now look at a picture of that Adonis and get lubricated really quick as I get older, it's going to take longer. I'm going to have to really, really stare at that picture, okay? So remember that in terms of education of your patients. The other kind of erection is called psychogenic, and that idea is that fantasies, smells, hearing, those kinds of things can cause an erection or cause lubrication with absolutely no physical stimulation. And women are more likely to have that than men, just because we are more attuned to the mind being a bigger sexual organ, all right? But what happens as people age is that if they could use more of that fantasy, it would help. And there's been some interesting literature on hypnosis and getting people to picture themselves having intercourse, and then they're able to get through that performance anxiety and have it. Or actually teaching people how to use fantasy to increase this idea, okay? Techniques to restore erection, if that is a very big important part to the male, there are different ways. There's vacuum pumps that can be purchased. If you purchase it through medical equipment place, it'll cost about $300. If you can find it in a catalog, it'd be under $50. It's the difference between saying it's medical or it's called Big John, you know. So it's all it basically is a cylinder that fits over the penis. It's a handheld pump that creates a vacuum, draws the blood into the penis, and then there's a rubber band that fits at the base of the penis. That's left on for about 30 minutes, and it usually creates a penis that's hard enough for intercourse. Again, it's real important that you don't have somebody who's a little demented and that wants that and leaves it on for 4 hours, because then he's going to wake up with a dead necrosed penis, all right? So you have to make sure that you're dealing with people who are responsible. The penile prosthesis requires surgery, but certainly they've made a lot of advances from the simple rods where people walked around with permanent erections to now they have things that come in 3 parts. They have the rods in the penis that are inflatable, and then in the scrotum they have a little pump, all right? And then the third part is the reservoir that's put into the pelvis. And what happens is when the male wants to have an erection, he or his partner pumps the scrotum, okay? Not the testicle, it's just in the skin. And so they pump, and the fluid from the pelvis goes into the prosthesis, and they get an erection. And then when they're done, they kind of fold over or just pinch the head of the penis, and then the fluid goes back into the pelvis. Now it sounds remarkable, it's lifelike, it's good because, you know, when you're wearing pants you don't have to have an erection. The problem is that it's mechanical, it comes in 3 parts, there's lots of tubes, so things go wrong with it, all right? You have to again make sure that you're doing the right thing, that these patients have been assessed and this is what they need. Intracavernous injections of vasoactive substances, it's a big long word. It basically just means that there are now medications that can be injected directly into the penis that can cause erections. They can last 20 minutes to 45 minutes. Again, this requires a physician prescription and visit to the urologist, but if this is important, it can be done, all right? Ejaculation requires also that the skeletal muscle be intact, and there's no blood flow involved here. And I don't want to take any more time. Communication. This is what they look like when you don't talk about it, okay? This is what they look like when you do. Okay. All right. Any questions? All right. Well, enjoy your evening. Okay.